All right, everybody, welcome back to another session. This one's going to be super exciting because we have Dr. Jill Krapf with us today. Thank you, Dr. Jill, for being with us.
Thank you for having me.
Now, we're going to talk about something that a lot of people can't even spell, let alone may not even know what it is, but that's vulvodynia. So, can you explain, what is vulvodynia?
Yes. So the vulva is the external genitalia. And so Odine was the little known Greek goddess of pain. So vulvodynia refers to an abnormal pain response of the vulva. And this includes a couple other pain conditions. So clitoridynia, everyone's heard of a clitoris. So clitoridynia is abnormal pain response of the clitoris specifically, which is a subset of vulvodynia because the clitoris is a part of the vulva. And then what people may not have heard of is the vulvar vestibule. The vestibule is that area inside the labia minora, or the small lips, at the vaginal opening. And it's one of the main sites for pain, actually. And we call that, you guessed it, vestibulodynia. So vulvodynia is a very generic, kind of non-specific term, just referring to pain in the vulvar area.
And how did you get into this being like your specialty?
Yes. So I am a board certified obstetrician gynecologist. I did a residency in OBGYN 4 years long, learned how to deliver babies and take out uteruses. I'm doing none of those things right now. So in my final year of training, I was assigned to a surgical case with Dr. Andrew Goldstein, who is one of my mentors and one of the forefathers of vulvodynia and lichen sclerosis. And so I participated in the surgery with him, and he started telling me all about vulvodynia and vulvar pain conditions. And I was about to graduate residency, become a full-fledged OBGYN taking care of real patients. And I knew about none of these pain conditions. And so this prompted me to spend an entire year with him doing basically a non-official fellowship, learning everything I could. And then after that, I started the Center for Sexual Health at a major university. I ran that for 5 years. The need was so great for specialists in this arena, treating vulvovaginal conditions and pain disorders and skin conditions like lichen sclerosis. And so I trained two nurse practitioners. And then I ended up moving to Texas for a while for my husband's military career. And I was doing the same thing out there, training residents how to evaluate the pelvic floor and really opening people's eyes to all of these conditions. And then in 2019, I had the opportunity to join my mentor, Dr. Andrew Goldstein, at the Centers for Vulvovaginal Disorders back in Washington, D.C. And I took that opportunity right away. And that's when I gave up obstetrics. And I decided to do this full time. And I'm so glad that I did, because it's really my passion, taking care of patients with these conditions.
Yeah, because I agree. This is not something that we ever covered in my OBGYN or Urogyne training. It was something I had to kind of teach myself on my own. And it's been a very interesting road. But do you know offhand how many women suffer with something like this?
Yes. So it's estimated that 16% of women have a vulvar pain condition in their lifetime. And so that's very high. And there's many different causes for these vulvar pain conditions, but it's definitely something that people go to their OBGYN for. And I can say, as an OBGYN, you know, too, that we're really not trained in a lot of these conditions. Or I think that's changing. So that's great. But there's so much more that we can learn. And some of it is that the research hasn't really caught up with us yet. But the research has really expanded and blossomed in the last, I would say, 10, even 5 years, when we're talking about clitoridynia and pudendal neuralgia and all of these things that are nerve related. So we're really opening our eyes and really looking for the cause of vulvodynia, because remember, vulvodynia tells you where the pain is located. It doesn't tell you what is causing the pain. And that's the key to treatment. Figure out the cause and the treatment will follow.
And that's a really good point because sometimes I would come across patients who like, oh, I have this diagnosis, and they get really excited. They're like, oh, if I have a diagnosis, then there must be an answer. But what are the different potential causes of vulvodynia?
Yes. So I see this all the time. And it is beneficial, I think, to have a diagnosis of vulvodynia because it's a place to start. And it's more beneficial to have a diagnosis of provoked vestibulodynia or even clitoridynia because that's a more specific place to start. But everything has causes, everything. And so what we're finding in the nomenclature when we talk about these things is that there's certain conditions that we have research on and we have a true understanding of. Things like genitourinary syndrome of menopause, which is the newer form of vulvovaginal atrophy. So that's no longer considered vulvodynia because we now know what the actual cause is and there's research behind it. But the other causes of vulvodynia are real. We're just on the edge of understanding them and accepting them. So the way that I like to think about it is that vulvar pain can be related to 4 different factors. And these are very broad buckets, right? Broad factors. One is hormonal. And so things like genitourinary syndrome of menopause, which we do know about, would be in that bucket, as well as things that are in the research right now, certain medications that can cause pain at the glands that produce our natural lubrication, the greater and lesser vestibular glands. We call that hormonally associated vestibulodynia, which is exactly what it sounds like. So pain at the vestibule due to lack of hormone or related to hormones. So the hormonal bucket is one such example of cause. Another one is muscle related. So things like hypertonic or overactive pelvic floor muscles. We know that this contributes greatly to these pain conditions, including dyspareunia or pain at the opening, as well as bladder symptoms that are related to things like painful bladder syndrome, or the former term for interstitial cystitis, and bowel symptoms. So we see a lot of IBS or irritable bowel syndrome that could be related to tightness of the pelvic floor. So that all goes into the muscle bucket. Then we have nerves, and this is really an exciting area. We have the role of the pudendal nerve, so we call that pudendal neuralgia. But again, neuralgia means irritation of a nerve, meaning the pudendal nerve. It doesn't tell us why the nerve is irritated. It tells us where the irritation is located. So there's many different causes of nerve irritation. And the end point, the end organ with pudendal neuralgia is the vulva, right? And the anal area to be complete, but really the clitoris. So we're finding that clitoral pain can be related to irritation of the pudendal nerve. We can see hemivulvodynia. So one side of the vulva is more sensitive than the other. That indicates usually a nerve issue, or even anal symptoms or rectal symptoms can be related to the pudendal nerve. We can also see too many nerve endings in the vestibule for different reasons. So we call that neuroproliferative vestibulodynia, meaning proliferation or too many nerve endings in that area. So very descriptive. The more descriptive we are, the better. And then the final bucket, the 4th bucket, is inflammation. And the way that I think about it is inflammation can be internal, meaning an autoimmune skin condition like lichen sclerosis or lichen planus or plasma cell vulvitis, or it can be external, meaning something contacting the area like a contact dermatitis, or it could be something that the body's producing that's causing irritation, like a desquamative inflammatory vaginitis, which is basically an inflammatory discharge for many different reasons. But if we're able to conceptualize it in this way and really look at the cause that's involved, then you can more specifically figure out the diagnosis based on a history and a full physical exam.
Oh, this is so informative. If a person is experiencing pain in their vulvar area, at what point should they go, all right, this is a problem and I really need to go get help? And the next question is like, where do you go? So,
Yes. So I would say that if the pain is what we call chronic, and the definition of that is greater than 3 months, but really we don't have to wait that long. We know if someone has a yeast infection, for example, and they take a yeast infection medication and the symptoms go away and they never return, okay, great, like problem solved, right? But if somebody feels like they have a yeast infection and they've tried the medications and it seems to go away for a little, but then it comes back, or it never really goes away fully, and then they're starting to see doctors and they're getting testing and the testing is negative or sometimes positive, sometimes negative. If we're getting into those types of situations, then we really want to consider some of these vulvar pain conditions and really look for an underlying cause. Even if someone is getting recurrent infections that are proven, we want to look at an underlying cause in that circumstance too, right? Because something is going on. We need to figure out why. Why is the skin susceptible? Why is the body having this reaction and so forth? And so your OBGYN is a great place to start. Even a primary care can be a great place to start. And then if you're having bladder symptoms, a urologist, and then there are specialists in this. And I want people to know that we are available. This is what we do. We want to hear about your symptoms, about your vulvar chronic pain. Like, this is what we do. And you can find specialists through different directories, depending on what your symptoms are or what is proposed as what's causing it. So a great place to start is the International Society for the Study of Women's Health, or ISSWISH, has a great directory of providers, and this is multidisciplinary. We're talking physical therapists, sex therapists, gynecologists, urologists, people from all different areas that are really interested in these conditions. And then say you think you narrowed it down to maybe a nerve issue, maybe pudendal neuralgia. There is something called Pudendal Hope directory, which has a list of providers as well as a list of physical therapists that specialize in pudendal neuralgia. Say you think you might have lichen sclerosis or a skin condition. There's the Lichen Sclerosis Support Network, and they have a directory of providers who are passionate and want to see these conditions. Dermatologists, gynecologists, again, multidisciplinary. So there are resources available, and I do want everyone to know about all the different resources.
That is great. And we're definitely going to have those all listed out. So that's a wonderful idea. One of the things I often see, and I definitely advise against this, is using Dr. Google, because we see this too many times. But if there was something that somebody should or should not be doing at home, can you, like, not necessarily, I mean, you're still having a problem, make sure, and even with this summit, I want to just remind everybody, this is for education and entertainment purposes. You really need to see your healthcare provider. But if there was something that they could or they should or should not be doing to help this condition, are there some things that they could do at home that you could mention?
Absolutely. And I do want to comment on the internet because it's natural. It's the natural inclination when we're having symptoms. And right, our symptoms always come up at like 3 in the morning,
Yes.
and oh, it's itchy. And what do I do? And, it's obviously very accessible to look online. I think that was one of my inspirations for being so vocal on social media, because if you're going to be looking, let me provide evidence-based information from a qualified board certified obstetrician gynecologist that specializes in vulvar pain conditions. Let me put that information out there, so people can have a direction of where to go, because everyone's going to be looking. I look myself, everyone does. So we might as well get some good information out there. But first step approaches are going to be to keep the area clean and dry, to really look at the products that are being exposed to the area, to look at what type of pads are you using during your menstrual period. Are you using a panty liner every day? If there are reasons that you're using it, look behind those reasons. If you have leakage, if you have a discharge, okay, maybe we should take a look at that and why that's happening. Check out your detergents. What's the fabric softener? Are you using a lotion product, or is there something that's aggravating the area? So that's the first step approaches. Sitz baths can be very helpful if there's fissures or cracks to the skin or what have you. A vulvar moisturizer can be very helpful as a first step approach and a symptomatic approach, just to make things feel better. But if these first step approaches are really not cutting it, that's when you really want to see a provider or a practitioner to really see what's going on and to give you more specific treatment options.
Because unfortunately, I think some women just think, oh, this is normal. It's kind of part of being a woman, and they just kind of grin and bear it. But yeah.
Yes, I see that all the time. I see that a lot with menopause and perimenopause, right? So things are changing, you're having symptoms, but you think, okay, this is how it's always going to be. I guess this is my new normal. But the reality is that that doesn't have to be. There are very, very safe treatments for many of these things. And there are medical reasons why these treatments are beneficial for prevention. We always talk about prevention in medicine, right? And it's not just eating a whole food diet and making sure your heart health is good and exercising. These things are very important. Mindfulness, everything is very important for our nervous system and our cardiovascular system. But your vaginal health and your vulvar health is equally as important. It's so important to keep those tissues healthy because then it's resistant against infection later in life. And we know that a lot of the causes of issues later in life are related to sepsis and infection. And if we can prevent those things, then it's not only good for quality of life, it's good for general health and well-being.
And I don't want to make fun of people that do things, but when you're in pain, people get desperate. So I'm going to ask you, what is the strangest thing you've seen somebody do for vulvodynia? Because one of the things I remember seeing was, and like I said, when you're desperate, you're just like, I'm going to try anything and everything. And I had a woman once who was using Ambisol, which is for toothache, and she was using it in that vulvar area, not meant to be used in the vulvar area. It actually caused worsening of the tissue because it would like burn the tissue. But what things have you seen in your practice?
Yes. So being a specialist, I've literally heard everything. There is nothing that anyone could say at this point that could surprise me. And honestly, the more extreme the measures, the more it almost breaks my heart inside. Just because I know that there are treatments for these things. And so I read it as you are being proactive. You are trying your best to really help your health. And we want to just make sure that I can assist you in that cause. And actually, the patients that try the most drastic things are actually the best patients because they just need a little guidance and then they're on the right track and they're sure to follow whatever I tell them. I would say probably the most heartbreaking thing I've seen is someone spraying Lysol on the area.
Oh,
I
yeah.
know. And
Ow.
so it's yes. And so it's and actually if you look back to ads from the late 1800s, this was actually advertised and a common treatment. So there is a historic sadness related to this, and it really does tie into how we think of our genitals, and it's really actually very deep. But yes, when I see the drastic things, I always take a step back and we think about health and well-being and really focus on that.
That's such a good point. And I loved how you answered that question. That was actually spot on. That was amazing. And I actually kind of got distracted from it because I'm like, oh, that's so, I mean, because it just shows your passion and your love for the subject and wanting to make people better, which I think that is amazing because sometimes in medicine we see too often doctors get burnt out and kind of lose that passion because of the way our health system is. And so I'm so happy that you're still doing what you're doing, and you're able to keep that and keep going with that.
Yes,
That
the secret is I get to know every single one of my patients
I
as
love that.
people. Right.
Yes.
I learn about everything because I have to. When it comes to a complex chronic pain condition, There are so many things involved. We talked about those 4 buckets. There's one really important bucket that I left out, and that is the psychology behind all of this, right? It's a biopsychosocial model. And there's the psychology, and there's also the social component of all of this, which we touched on when we were just talking about that previous discussion. But it's so important to find out, what are my patients' biggest fears, right? What are they most concerned about? What do they think is going on? My favorite question, I give a very lengthy questionnaire before patients come in for a consult with me, just to get my wheels turning and really get to know that person and they can fill this questionnaire out just with themselves, right? And so it's the best way to do it. And my favorite question is the final question, and that is, what do you think is going on? And I have to say, my patients are amazing. They amaze me every single day. They've been through it. They've seen an average of 7 doctors before they come to my doorstep. And I will tell you, even if they don't know the medical words to use, 9 times out of 10, they know exactly what's going on. And it really, I really see it as us partnering together. They know their body better than anybody, better than anybody. I know the science, right? I may be the specialist in this, but we need to work together. It's like being a detective to figure out what's going on. It cannot be one-sided. It has to be a team effort.
I came across a study not too long ago that said 65% of women are uncomfortable saying the word vagina. And I mean, I know in here we're even getting in deeper because we're talking about vulvas and clitoris and labia and vestibules and everything. But just the fact that we can't even talk about these parts and there's still a lot of shame and embarrassment. Um, how do you kind of, I mean, I know one of the things that you're doing is you're all over social media and trying to normalize that conversation, but how do you get women to kind of overcome and start using that language? Because if we can talk about it, then we can ask for help and we can heal. So
Yes. So a big part of my exam so I was an educator. I still am, but I was a clerkship director for residency for about a decade, almost a decade. And so we talk about the hidden curriculum, right? It's not just what you learn, but it's how you learn and the intricacies of what's behind the learning and what's around the learning. And it applies to medicine as well, because essentially what I'm doing is I'm teaching, I'm educating my patients, and I educate my patients just like I educated my medical students and residents. My patients know more sometimes than certainly what my medical students knew when I was educating them within the clerkship. And I give them that responsibility because they deserve it, right? They are more invested than anybody, according to adult learning. We care, we want to learn about what we're very invested in. And if you have a condition, you are very invested, let me tell you. So I do a vulvoscopy, which is basically where I take a look at the vulva with a microscope, and I have a camera that attaches to a screen. So we can all look together, the patient and myself, up on the screen, and I give everyone a tour of their vulva, because oftentimes it's the first time that anyone has shown them what their parts look like. And to be honest, we never really look until there's a problem, right? So we don't
yes.
know what it's supposed to look like or what's expected, right? And so the reaction that I see from patients tells me so much, because I will have people that will respond, "Oh, I can't look. I can't look. I'm so disgusting. This looks awful," right? And we have to work on that. When we talk about applying a treatment or something like that, we have to address those feelings and those sensations and that gut reaction, right? Where does that come from? And then I'll have other patients that say, "Oh, cool. Wow, let me see that. Wait, go back to that area. What's that? Pull that over." And so depending on how you're approaching it changes my treatment regimen for you. Maybe not in the medications, but how we get the job done, right? How we how we apply the medications. Are we going to be using a mirror? Are we going to be using it based on feel? What's going to be the best treatment for you? Do we need to do some desensitization first? How does that look? And so really where someone's coming from is extraordinarily important, because everybody's a little bit different. And I cannot always predict it from just meeting somebody until we really get into the exam, right? People have surprised me over and over. And I have people say, tell me what you really feel about this. How are you feeling right now? It's normal to be a little nervous, and that's okay, but just communicate with me every step of the way. So we're getting there. We're getting there. I see generational differences in this as well, right? I see differences based on relationship status. Divorcees who are in the dating pool may be a little bit different than someone who's been married for 40 years. Like, we definitely see differences. So we have to meet the patient where they are.
For people who are not having problems with their vulva, what things should we be doing to keep it healthy?
That is a great question. I think that everyone should have a baseline look. Just take a look, really, just, you never know. And so just knowing what your parts are called, referring to the areas of the vulva without shame, really teaching the next generation. I have a 4-year-old daughter, and everyone on social media knows that she knows that the vulva is on the outside and the vagina is on the inside. And really just taking the power back here, right? When we talk about things with pet names, when we avoid talking about these areas, we're giving our power away, and we want to take that power back, because it's not only important to use these terms with your partner and be very specific in what feels good and what doesn't feel good and the areas, and knowing yourself, right? The first step is knowing yourself, and then you can communicate it to someone else. It's also important to be able to communicate it to a health care practitioner, your doctor, your nurse midwife, your nurse practitioner. You really need to be able to communicate these things, because it is a barrier. I've had whole discussions where people are talking about their vagina, and I know that they're not talking about their vagina. They're talking about their vulva or their vestibule or their clitoris, right? And so really that's the first, that's definitely the first step, is getting to know your body, yourself, taking that power back. And then as far as vulvar care, it's really treating your vulva like you would your face, right? Gentle cleanser, really less is more in this area. You only need water to wash this area. Really just, again, less is more. That's all I can really say. We don't need these feminine hygiene products. We don't need to smell like flowers and peaches and pineapples. Like, it's really not necessary, and it can actually do some more harm than good.
This has been great. Is there anything that I didn't ask you about vulvodynia that you want us to know?
Oh my goodness. I could talk about vulvodynia for a week
I know.
straight.
I could too. I would, and especially with you. This has been so much fun. Yeah.
I think we really hit the basics. I think that the important thing about this is know yourself, know your body. Less is more when it comes to products in this area. If there is an issue, don't hesitate to reach out. If first line approaches are not working, there are specialists that would be happy to see you and take care of this. And then the other thing I do want to say is that we do have a book that goes through all of this. So I am one of the co-authors of a book called When Sex Hurts: Understanding and Healing Genitopelvic Pain, right? We're just being very direct in this, because that's what you have to do. So if you are somebody that is not happy with how sex feels, if it hurts, if you have daily pain, if you have pain anytime you insert a tampon, if you have anything that has to do with the vagina or vulva, this book can be very, very helpful. And so I encourage everyone to take a look at that. If you are a practitioner, this book is extraordinarily helpful. It really breaks things down. It's evidence-based. There are references. It's guideline-based. It's written by 3 experts in vulvovaginal conditions and 1 amazing sexologist who has published more than almost anyone on this. She's incredible. And so there's 4 authors in total, 2 males, 2 females. We really have it covered generationally. And there's so much good information in this book.
Oh, that is amazing. So everybody go check that out. And Dr. Jill, where else can people find information about you?
Yes. So you can find me on Instagram at Jill Krapf, MD. And then I'm also on Facebook, same name. I dabble on Twitter a little bit, but it's not my main area. I'll be honest. I'm just a very visual person when it comes to explaining these conditions. I have infographics. I just need to, I have videos. And so those are the main places that you can find me. And then I'm currently at the Center for Vulvovaginal Disorders. I'm practicing in Washington, DC, but I'm going to share something. I'm about to actually open up a CVVD, Centers for Vulvovaginal Disorders, in Tampa, Florida. And that's where I will be starting in the fall. I'm going to be seeing patients in Florida. So we'll have offices in Tampa to service Florida and the Southeast. We'll have an office in Washington, DC, as well as New York. And Dr. Andrew Goldstein will be in New York and Washington, DC. We have a new provider joining us in Washington, DC as well. Her name is Dr. Kaylee Moss. And then I will be down in the South in Florida.
Oh, that is so exciting. I love that area of Florida too. That is so exciting. Well, thank you so much for taking the time to be with us. I really appreciate it.
Thank you.